My name is Andreas Pfützner. I'm a chemist and a physician, and I'm professor for internal medicine and laboratory medicine at the University for Digital Technologies in Medicine and Dentistry in Wiltz, Luxembourg. Today's topic is intact proinsulin, which is a key biomarker for beta cell dysfunction in diabetes. Diabetes is a global pandemic. The number of patients grow every year by about 10%, and we have incidences in some countries that exceed the others, and it is usually the fact that society turns from natural food more into Western civilized processed food that leads to increasing numbers. And current hotspot countries are, for example, India and China, that have a dramatic increase in the cases. Diabetes is diagnosed based on blood sugar levels. When you have a fasting level above 127 milligram per deciliter, which corresponds to 7 millimolar, or after a glucose challenge, when you ingest 75 grams of glucose and you test 2 hours later, if your level is above 200 milligram per deciliter or 11.1 millimolar, then you are defined and diagnosed as being diabetic. The problem with this diagnosis is the diagnosis is only based on blood sugar levels. And diabetes is a far more complex disease, and focusing on blood sugar alone does not really tell the story, and treating blood sugar alone also does not solve the clinical issues. So let me show you how we consider the pathophysiology of type 2 diabetes to be, based on more than 400 clinical studies that we have run and more than several thousand patients that we have been treating. Everybody agrees that diabetes has something to do with weight gain. Weight gain leads to a hormonal secretion that comes out of the lipid tissue, to be more precise, out of the visceral lipid tissue, which has a lot of functionalities, and there are more than 200 hormones that have been diagnosed, so-called adipokines. But all these adipokines have one thing in common: they all act against insulin. This leads to the situation that the body's own insulin cannot really work, or doesn't work as good and as effective as normal, and this condition is called insulin resistance. Insulin resistance leads to an increased demand for insulin to control the blood sugar levels, and the beta cells of the pancreas, these are the insulin producing cells, they indeed produce more insulin. Insulin, on the other side, is the only hormone that we have that can build up lipid tissue. And this information closes the circle, because what I'm describing to you here is not diabetes. This is just a normal physiology, because this situation allows the body to tolerate higher amounts of insulin that can be used for lipid tissue formation, without suffering at the same time from too low sugar levels from hypoglycemia. And this condition was an evolutionary advantage about 30,000 years ago, when we did not have access to excess food or to enough food every day. When the clan was successful and hunted down some animals, or the family was successful to find berries, then we had enough to eat for a temporary time frame, but that was usually followed by times of starvation. And obviously those individuals that were capable to build up lipid tissue, hence to store energy, at that time, were the ones that had later a better survival at the times of starvation, where they had the energy in the body that could live from it. So this is not diabetes, this is just normal physiology. Diabetes comes into the play when there is indeed this genetically driven risk for beta cell malfunctioning or beta cell dysfunction. And without these genes, you will never develop diabetes. At the same time, these genes, which are not really well described, so there might be several of them, and they have not been identified yet and described yet, but definitely the genes lead to the situation that the insulin secretion doesn't occur properly, and this finally leads to the problem. And you need to know that insulin is built in the pancreas and by the beta cells based on a precursor molecule that is called proinsulin. And when we have our beta cell dysfunction, it takes a little time, but sooner or later, we also see a secretion of proinsulin into the blood. And proinsulin can lower glucose as well. And at the same time, it doesn't have the same efficacy like insulin. It only has 10 to 20% of the glucose-lowering efficacy of insulin. But unfortunately, it has the same potency to build up lipid tissue. So it's an unphysiological hormone that can also build up lipid tissue. And because we have much more in order to lower the blood glucose, there is an increased tendency of people to gain weight when they are in this condition. This condition is described by the situation that you don't know why, but without changing your nutritional behavior, you are gaining weight constantly over a period of a couple of months or a couple of years. And unfortunately, the glucose levels stay low because proinsulin is also capable to lower it. And that leads to a situation where you are in acute danger for other comorbidities. Because now when the weight gain occurs, when the lipid cells are formed, this leads to the secretion of other hormones as well. And the activation of cell growth leads to a secretion, as an example, of a hormone that is normally used by the kidney to control the blood pressure and to lift the blood pressure. Because the kidney needs a certain filtration pressure, it has the right in the body to lift blood pressure up with a hormone called angiotensin. And angiotensin, when it's secreted, leads to arterial hypertension or increased blood pressure. And this is why we see high blood pressure normally as a comorbidity in our patients. In a second step, we need lipids to build up the lipid tissue, because once the stem cells have been differentiated into pre-adipocytes, these pre-adipocytes, they incorporate triglycerides in order to become mature fat cells. Hence, we have to have more triglycerides, and this leads to a situation that is considered to be a lipid disorder with hypertriglyceridemia, and in turn, because of lipid metabolism, to low HDL cholesterol. At this point, it's important to understand that elevated LDL cholesterol is a completely independent disease which has nothing to do with diabetes and which needs to be treated separately from the diabetes conditions. But at the same time, hypertriglyceridemia and low HDL is very common in our patients. Finally, we need to understand that whenever stem cells differentiate to become a certain cell type, this leads to the possibility that there is the formation of cancer cells, so a certain mitogenicity, very, very limited number of cells, but it can happen. At the same time, we do not become cancer patients when we grow obese. And the reason why that doesn't happen is the fact that the immune system gets activated, and immune cells, so-called macrophages, are penetrating into the lipid tissue, and they destroy every cancer cell that occasionally occurs on the spot. And to be able to do that, they need to be activated. An activation of immune cells is usually called an inflammation. And this inflammation cannot be induced simply in one organ. If the immune system is activated, it happens everywhere. And this includes the cells that are circulating in the bloodstream, in the circulation. And if you now know that activated macrophages, which are loaded with oxidized cholesterol, form the morphological basis when they penetrate into the vessel wall for atherosclerosis, for calcifications in the arteries, then you understand why our patients have an increased risk for atherosclerosis that can ultimately lead to coronary artery disease, myocardial infarctions, and a stroke. Well, if you look at this complex picture of the pathophysiology of type 2 diabetes, you may realize that there is one word missing that we normally take into account when we speak about diabetes, and that is indeed the word glucose. because you can have all these conditions without elevation of blood glucose, which makes it so dangerous if we oversee this period. However, when the glucose levels cannot be controlled anymore because the insulin and proinsulin that are secreted are not sufficient to really normalize the blood glucose levels, then we obviously have an increased risk of further deterioration. We will first see hyperglycemia, elevated glucose levels. This obviously increases the demand for insulin even further. And secondly, elevated glucose above 10 millimolar or 180 milligram per deciliter is an independent risk factor for the development of atherosclerosis and the sequelae that can be quite fatal. However, when then glucose is not well controlled, glucose toxicity as well as the complex secretion disorder lead to the development of further complications that can affect the eye. So the eye disorder, retinopathy, can affect the kidney, nephropathy, can affect the nerves, and also can affect the vasculature, leading to infarctions, to stroke. And in fact, more than 3/4 of patients with diabetes ultimately die from a heart attack or a stroke. So when we look at the diagnosis and what is measured, and if we look at the reality in the clinics today, the picture becomes quite dark. My fellow doctor colleagues are measuring hemoglobin A1C and glucose. They might look at the weight or the body mass index. But if they determine something in the lab, it's usually blood glucose, it's the lipids, and they can also clinically measure the blood pressure. But as you can tell, these are solely symptoms of the disease. This has nothing to do with the underlying disorders. And through our work over the past 2 decades, we have developed a biomarker panel, a biomarker concept that is composed of 3 biomarkers, which are high sensitivity CRP, intact proinsulin, and adiponectin. Our talk today is about intact proinsulin, so let me briefly explain the other 2. High sensitivity CRP is a marker for chronic systemic inflammation, and it is accepted in particular by the cardiologists to be a predictor for the risk of macrovascular events and myocardial infarctions. So in our case, this is the indicator of chronic systemic inflammation. And then we have on the other side adiponectin, which is a positive hormone, the higher the better, that indicates the acceptance of the body for insulin. So the higher it is, the lower the amount of insulin resistance. For example, if people lose weight, then usually adiponectin goes up and vice versa. And then finally, we have intact proinsulin, which is the key biomarker for the beta cell dysfunction that is basically the basis for the development of diabetes. So let me explain a little bit about proinsulin. Proinsulin is the product after remission and translation of the genes into the protein. It's basically being formed at the ribosome, and then it's being cleaved into insulin and C-peptide, which both are active hormones that are required by the body. This happens usually after the production in vesicles, which slowly go to the cell membrane. The insulin and C-peptide are stored under normal circumstances at the membrane and are secreted if needed. In a pathological situation, when there is an elevated production, when the cleavage capacity gets exhausted, then we see the situation that there is an incomplete cleavage of intact proinsulin, and then ultimately next to insulin and C-peptide, intact proinsulin is also secreted into the bloodstream. And as I mentioned earlier, it is capable to lower blood glucose, but not as good as insulin itself. However, we have strong indication in the literature that independent from the glucose levels, intact proinsulin shows a harmful process that then happens in the vasculature. And as an example, I'd like to show a study that has been conducted in Sweden, where they observed 1,000 men over a period of 27 years, and were looking at the morbidity of these patients. What they did is, in this study, they eliminated everybody that had developed diabetes out of the analysis. Hence, the analysis that I'm going to show you is solely for those people that officially never developed diabetes. In general, they had a mortality of approximately 10% over the 27 years, and the main cause of death was heart attacks and strokes. And when we look at people with low or with moderate elevation of intact proinsulin, it is the same, but if proinsulin is elevated, there is a 300-fold increase, or a threefold increase, or 300% increase in cardiovascular mortality if intact proinsulin is elevated. And this is due to the conditions that I mentioned earlier. So people that have normal proinsulin levels have a low risk, but people with high proinsulin levels have a high risk for a myocardial infarction or a stroke. And this is related to the fact that when insulin binds to the receptor in the arteries, it can still protect against any atherosclerosis effect, but when proinsulin binds to the same receptor, it always causes atherosclerosis. And that is why elevated proinsulin is an independent risk factor for macrovascular disease. Now, there are obviously possibilities how you can use this biomarker now in the clinic, and if you are a strong believer that diabetes is glucose elevation, then you can at least use this parameter to tell that if it's elevated, it means that there is a close and near time coming development of type 2 diabetes based on the glucose definition. And this has been found in many studies, including the one that I just mentioned, because that study also showed that elevated levels predict type 2 diabetes, and this happens within the next 7 years. There is another study showing that also development of type 2 diabetes within 7 years approximately. And a study in Finland that was done with more than 15,000 patients showed that either fasting or glucose-stimulated intact proinsulin is indicative for type 2 diabetes development in the Finnish population within the next 5 years. I did a small study showing exactly the same thing, that elevated glucose-stimulated intact proinsulin in normoglycemic patients also is indicative for type 2 development within the next 5 years, and the same is true for children. Appropriate studies have been conducted. Now, what can we say now? What are causes for elevated intact proinsulin? So how specific can it be? Well, it's very simple. It is super specific, because when you have elevated proinsulin, it can only happen because you have beta cell dysfunction that leads to type 2 diabetes. And this is the case in more than 99% of the cases. In around 1%, it can be that you are developing type 1 diabetes, so autoimmune diabetes, and very close to manifestation, there is a period when the beta cells secrete everything they have to lower the glucose levels and don't even take the time for appropriate processing. That's a short time frame of few months or maybe a year in late onset of type 1, but that can be the case as well. And then even more rare is a benign tumor of the pancreas, the so-called proinsulinoma, and we see less than 3 to 4 cases per year in Europe, which are also clinically quite apparent because they will suffer from frequent hypoglycemia. Those are the only reasons why you can have elevated proinsulin levels in a fasting blood sample. Hence, it's very specific for development of type 2 diabetes. So, it is the biomarker of beta cell dysfunction, and when you want to interpret the results, if you do so in a fasting sample, we have shown that levels below 1.9 picomolar, which is our lower limit of detection of our assay, they mean there is no indication of beta cell dysfunction. If the fasting level is between 1.9 or between 2 and 7, 7 is the upper threshold, this means that It is not there in the fasting state, but it's possible that when you challenge the pancreas, that during the glucose challenge experiment there will be an elevation that goes beyond the normal range. If it is above 7, then you already have beta cell dysfunction in the fasting state, and you also have insulin resistance, and this is completely independent from the glucose values, as I hopefully have been able to explain to you earlier. When we now go for the interpretation of the levels during a glucose challenge experiment, and so when we look at the 2-hour value, what we can say is if the intact proinsulin level is below 7, then there is no indication of beta cell dysfunction. But if the level is above 7, this means that you have beta cell dysfunction under stress. And this is indicative for a current diabetes development, and in particular, it is also indicative for an increased macrovascular risk because, as I mentioned earlier, elevated intact proinsulin also always means a challenge for the vasculature. And we have used this information based on the fasting levels to even introduce a staging of beta cell dysfunction, just to be able to describe the situation. So when everything is normal, glucose as well as intact proinsulin, but the patient, for example, has already diabetes, which is possible in a postprandial state, then we talk about stage 1 of beta cell dysfunction. Stage 2 means in the fasting stage we already have insulin resistance, as it can be shown, for example, by the HOMA score. But at the same time, there is yet no proinsulin secretion. That's stage 2. Stage 3 starts when we see increasing proinsulin levels, and the higher the stage, also the higher the risk for cardiovascular or macrovascular events. There is a stage 3b, and this is when the beta cell production completely gets exhausted and actually turns down again. And that's the worst stage, because at that stage we already have a highly elevated cardiovascular risk. It is to be understood that this staging can be completely independent from the glucose levels, because the secretion product, irrespective of whether it's insulin or proinsulin, both can reduce the blood glucose levels. So in conclusion, what are the features of intact proinsulin? It is definitely indicative for beta cell dysfunction and destruction in diabetes. It lowers blood glucose with about 10 to 20% of the insulin efficacy, and at the same time it has the same lipid building effect. Hence, it can lipids with the same efficacy than insulin, and because we need more to lower the glucose levels, we have an increased development of lipid cells, first pre-adipocytes and then adipocytes, and this leads to chronic systemic inflammation and already an increased risk for macrovascular events. And finally, proinsulin leads to atherosclerosis when directly binding to the vascular insulin receptors. So by all means, in our treatment, we have one target, and this is to lower intact proinsulin levels in parallel also to the glucose levels. Let me show you a practical result from our investigations. It was already mentioned earlier in the literature list, but when we did a study with 20 patients, that we did in order to collect samples for the determination of the normal reference range, it turned out that we were able to see the same patients again 5 years later, and it turned out that 4 of them had in the meantime developed type 2 diabetes. So we did the analysis and looked at all the parameters of this oral glucose challenge test to figure out whether any of them could have told us and could be predictive for this diabetes development. Well, when we look at the 16 patients that did not develop diabetes, which is the straight line, and the 4 patients that developed diabetes, we could not see anything at that time with the glucose levels. They were completely similar. And the same was true for the insulin levels themselves. So insulin behaved completely similar. But when we looked at the proinsulin levels, we could have told already prior to the diabetes development, that there is this indication of beta cell dysfunction that ultimately has then led to diabetes development. And as mentioned earlier, we are not the only ones. Others have seen that same thing with larger patient cohorts, but it is only intact proinsulin that can tell the story. I would now like to show you a few patient examples. The first one is a patient where we employed what we call the personalized diabetes treatment. It was a 62-year-old lady that came up with elevated proinsulin levels and elevated HbA1c levels, and we identified a treatment for her which was composed of the combination of a GLP-1 agonist, liraglutide, with a sensitizer, pioglitazone. And in order to prolong a little bit the action of the liraglutide, at that time we used sitagliptin, a DPP-4 inhibitor. This combination sounds strange, but it worked. As you can tell, we look here over a period of several years. There was neither an indication through intact proinsulin that there would be a disease progression, nor through the HbA1c levels. Everything remains stable and flat over the entire observation period. We did not change anything in this treatment. It was definitely a perfect match here, and hence there was no need to do anything further than that until to date. The second example shows the example of a male patient, and you can see here again the course of HbA1c, and the course of HbA1c was always normal. There is no elevated HbA1c levels, again over a period of more than a decade. And you can tell that the one thing that we used in addition to his personalized treatment, which was a combination of pioglitazone and saxagliptin, that when we realized that proinsulin goes up again after 2 years, we intensified our efforts to make and help him lose weight, which we really achieved. And that led to the situation that he had very stable glucose control, also no indication of disease progression. And our driver for deciding on this intensification of treatment was always just the proinsulin levels. So when you treat the underlying conditions, you more or less automatically see an improvement and a normalization of the glucose levels and of HbA1c as well. This can nicely be seen in the next example. It was a patient where we employed what we call de-escalation treatment. De-escalation treatment is a combination therapy which is employed for a temporary time frame. It's usually done for 3 months. It's a combination of 4 drugs, each of them effectively addressing one of the underlying conditions of the disease. So we usually use small doses of a basal insulin, we use a GLP-1 agonist, we use a sensitizer, pioglitazone usually, and we use an SGLT2 inhibitor. Everything with low doses. We give this in parallel, and as you can tell, if you give this for 3 months, we saw the normalization of HbA1c and the intact proinsulin levels here. And moving forward over a period of, this shows the period of 7 years. I have treated this patient in the meantime for more than 12 years with this concept. After the de-escalation treatment, there is a rejuvenation effect on the beta cells, and then the patients can go for quite some time without any drug treatment, so just with lifestyle only. And as you can tell, this lasted for approximately 2 years. Then we saw an increase again in intact proinsulin, and that drove us to repeat the therapy despite the fact that glucose or HbA1c hasn't really changed. So we re-employed this treatment, and again it lasted for 2 years. And then we had the situation again that it increased again, so we repeated it again, and we did so 4 times. You can see that driving the treatment just through the proinsulin levels was sufficient to keep glucose and hemoglobin A1c under control for a period of now more than 7 years. We are reaching already the 12th year of this treatment, and it actually continued exactly the way you are seeing it here for now. So focusing and targeting hemoglobin A1c is one thing, and that's the accepted one all over the globe. But targeting intact proinsulin as your treatment target is by far more effective. With this, I would like to summarize a little bit the clinical features of the biomarker. So, elevated proinsulin in the fasting stage indicates a massive and pronounced beta cell dysfunction and insulin resistance. It's a predictive marker for infarction and stroke risk independent of glucose control. It's often the only indication of progressive diabetes development when glucose and HbA1c levels are still in the normal range. And if you look at elevated proinsulin in the glucose challenge test after 2 hours, then it allows for early detection of prediabetes or diabetes. It indicates progressive diabetes development. It indicates a high cardiovascular risk and allows for early intervention, so you can intervene through lifestyle measures and everything to delay the manifestation of a glucose-driven diabetes. And it is also a monitoring biomarker during therapy. If you manage to keep intact proinsulin low, then you also manage to keep glucose in the desired treatment range. Now finally, some technical details. What does this mean for the patient if he has elevated proinsulin levels? So what does it mean? In case that you have diabetes in your family, so you understand you are at a certain risk, then it would be great if you have intact proinsulin determined through your regular checkups that you do with your doctor in order not to oversee the progression and development of type 2 diabetes. Just remember, if one of your parents is type 2 diabetic, then your risk is 50% that you have it as well. If the levels are above 7 but blood glucose are still normal, then beta cell dysfunction associated with diabetes is already prevalent. And we call this normoglycemic diabetes, or you have normal glucose values but you already have the disease. And in this situation, a race takes place in your body. What comes first? Is the time sufficient to have an official manifestation of your diabetes based on the glucose levels, or maybe you have a heart attack before it's ever being discovered? And the development of further chronic comorbidities like hypertension or lipid disorders can take place in parallel without diabetes being detected to be the original reason for it. Just keep this in mind. The other thing is that once you have this condition, it would be great if you're able to identify a doctor that doesn't wait for glucose to go up before treating diabetes. And the number of physicians is increasing right now that are willing to actually start treatment even earlier, for example, based on the intact proinsulin levels. They are not waiting until finally glucose goes up, in the understanding that elevated proinsulin is already indicative for an increased cardiovascular risk. So some technicalities for the assay. How is it measured? So we are determining intact proinsulin by means of the TICO Medical Human Intact Proinsulin ELISA. And you can do this test in different samples. So it can be serum, it can be EDTA, it can be heparin plasma. I personally prefer to use EDTA plasma. Why? Because it is a sample that I'm taking anyway for the HbA1c determination, and I can simply ask the lab to add the intact proinsulin measured out of the same sample to provide it on the result sheet. And the good news is that in EDTA plasma, the samples are stable even at room temperature for more than 2 days. If you put it in the freezer, it's actually stable for several years, which allows you also to preserve the information. Another technicality that I would like to mention here is the fact that only intact proinsulin as a test gives us the result. There are other tests available measuring total proinsulin. So what is the difference? Intact proinsulin is basically the freshly produced proinsulin coming out of the pancreas with a half-life of 15 minutes, while total proinsulin is intact proinsulin plus the unspecific degradation products that occur in plasma. And the problem is that these degradation products have a survival rate of several hours, meaning that if intact proinsulin was once elevated and goes down in concentration again, still total proinsulin will be elevated for the entire follow-up period. Hence, it loses its specific character to tell us what the beta cell is currently doing. So only the intact proinsulin is a direct measure of pancreatic beta cell function. And from a laboratory medicine standpoint, it's also the only one where we do have an international reference standard as defined by WHO. So it is the only one of the two where you are able to compare intact proinsulin values from different laboratories, as they are all forced to use the same standard if they want to use and determine it in a valuable way. With this, I would like to conclude my lecture by thanking you for the attention. I hope I have been able to give you more background information for this valuable parameter that I use to direct my treatment with my patients with diabetes. Thank you for your attention.